Thank you for joining me for this interdisciplinary clinician nutrition education program. Today we will be discussing the role of nutrition in recovery from lung transplant. There's also a list of proposed recommendations for improving the provision of nutrition intervention in the post-transplant clinic. My name is Josephine Wiles. I'm an MPH student and I'm about to finish my dietetic internship at the USF College of Public Health. During my clinical rotations, I rotated through the lung transplant team at TGH, where I found a new passion and learned a tremendous amount about how nutrition status plays a role in organ transplant. I enjoyed working with Jahira Pluis and Stephanie Costello as mentors, and I asked for the opportunity to return to complete a special project investigating areas for quality improvement in nutrition intervention post-lung transplant. I've created this brief educational video to share what I learned and to serve as education should these changes be implemented in the TGH lung transplant clinic. A brief outline of today's session includes discussion of the purpose and objectives of this project, a brief overview of the literature review, the proposed nutrition intervention guidelines, a discussion for future directions, and a list of references. The purpose and objectives include: this project aims to highlight the impact of nutrition intervention on improving outcomes from common nutrition-related comorbidities in transplant recipients, and it serves as an opportunity to better understand the efficacy of the RDN on the multidisciplinary healthcare team following lung transplant. The purpose of this project is to increase the utilization of nutrition counseling and education sessions with the transplant RDN to improve transplant outcomes and reduce nutrition-related readmissions. One goal of this project was to create a list of recommendations or propose recommendations for quality improvement with nutrition intervention provision. So now we're going to discuss the literature review, and this slide is literature review and dietary interventions post-transplant. So nutrition post-transplantation is crucial but under-researched. Optimized nutrition boosts outcomes and survival. Absence of specific guidelines for the nutritional management of lung transplant recipients may require clinicians on the multidisciplinary team to use clinical judgment to optimize the nutrition status of recipients. The early phase focus is going to be to correct deficiencies, support healing, and enhance immunity, whereas the chronic phase focus is going to be to manage comorbidities like the new onset of diabetes after transplant, NODAT, obesity, dyslipidemia, hypertension, and osteoporosis. Efforts to establish guidelines are ongoing, and current advice includes early intervention, long-term dietary strategies or patterns like the Mediterranean diet, and nutrition counseling. Now we're going to discuss what I found in the literature review on post-transplant diabetes mellitus. So it should be noted that risk factors for developing NODAT include the traditional risk factors for type 2 diabetes mellitus, along with the exposure to the immunosuppressant drugs such as the corticosteroids and calcineurin inhibitors. Transplant recipients with DM have an increased risk for mortality, infection, and graft dysfunction. There was a single-center observational study where Rue and colleagues organized 267 lung transplant recipients into 3 groups: those with pre-transplant diabetes, those with NODAT, and those with no diabetes. They found that 29% of the population had pre-transplant DM and another 19% developed NODAT. This center set up a structured diabetes management protocol in the post-transplant phase, which included the use of insulin, visits with a diabetologist, and a nutrition and physical activity education program put on by nursing and clinical dietitians. Interestingly, in this study, the incidence of pre-transplant diabetes increased mortality risk post-lung transplant by 1.82. However, the NODAT was not linked to increased mortality after transplant in this population. This could potentially be attributed to the protocol described in this study for the organized management of blood sugars in the recovery phase. There are currently no published studies testing the efficacy of RDN intervention in the management of diabetes after transplant. Dobro and colleagues summarize in a review of research that healthy behavior interventions involving an RDN demonstrate positive outcomes in older adults with type 2 diabetes. Some of the strategies implemented in the reviewed studies included nutrition education and counseling sessions, meal plans, exercise, and motivational interviewing. Results included reductions in A1C levels, decreased dependence on insulin and glucose lowering medications, and other parameters such as body composition, weight, and other metabolic measures. RDNs play a pivotal role on the multidisciplinary team, and other approaches such as diabetes self-management education and support programs have demonstrated the effectiveness of this collaborative approach. This slide is titled Dietary Interventions and Post-Transplant Malnutrition. So malnutrition is associated with poor transplant outcomes. In a retrospective cohort study, researchers found that over a 5-year period, patients with severe malnutrition had a higher mortality rate at 44.6% than those who weren't malnourished at 38.9%. The leading cause of death was infection, and there was a higher rate of death from graft failure and pulmonary causes in patients who were classified as severely malnourished based on the Nutrition Risk Index. Malnutrition has also been associated with longer length of hospital stay, increased mortality, decreased quality of life, and decreased functional status. RDN should utilize nutrition assessment to understand the severity of malnutrition and provide patient-centered intervention and monitor progression. Most of the published research on the impact of malnutrition on lung transplant discusses the impact of malnutrition pre-transplant on post-transplant outcomes. It is estimated that between 30 and 59% of patients with end-stage lung disease that have been approved for transplant have some degree of malnutrition. While there have been no experimental trials conducted on RDN impact on malnutrition in the transplant population, a multi-center trial evaluating the impact of individualized nutrition support for inpatient medical patients at risk of malnutrition, identified by the NRS 2002, found that patients receiving personalized dietary intervention overseen by a trained dietitian had a significant reduction in adverse clinical outcomes and mortality within 30 days compared to those receiving a standard hospital diet alone. In a different multimodal nutrition intervention randomized control trial, Monk and colleagues found that a multimodal nutrition intervention, including nutrition counseling from a dietitian at 4 days, 30 days, and 16 weeks post-discharge, improved older malnourished patients' quality of life, nutrient intake, and physical function. There was no significant difference in 6-month readmission rates between control and intervention groups. Both studies underscore the crucial role of dietitians in optimizing nutrition support strategies with tailored interventions for the malnourished patient or patient at nutrition risk. This slide discusses dietary interventions and post-transplant weight management. There is a general trend of weight gain after transplant, often attributed to abnormalities in energy homeostasis and corticosteroid usage, which are known to cause weight gain through a couple of different mechanisms, including potentially causing leptin resistance. Due to changes in immunosuppressant and corticosteroid usage from the acute to chronic post-transplant phase, energy metabolism is not static, and periodic reassessment of caloric needs should be a part of post-transplant nutritional management. However, individualization of nutrition intervention is required as some weight gain after transplant may be healthy. In a single-center longitudinal retrospective study, Jomfy and colleagues found that patients with a low or healthy BMI at transplant with a weight gain of greater than 10% at 5 years had a 64% decrease in mortality risk compared to those who had maintained a stable weight. The impact of dietetic counseling and education was tested in a non-randomized pilot study aiming to mitigate unintentional weight gain post-transplant. Participants in the intervention group received the standard of care enhanced with targeted dietitian-led education sessions on the American Dietary Guidelines with individualized telehealth consultations post-transplant. Results revealed that the intervention group experienced comparatively lesser weight gain than the control group, suggesting a potential beneficial impact of dietitian intervention. Now that we've finished discussing what I found in the literature review, we are going to shift gears into discussing the product of this project, which includes some proposed recommendations for quality improvement in the provision of nutrition intervention post-transplant. One of the goals of this project was to create a list of proposed recommendations that could potentially be implemented within the clinic. The list on the left consists of recommendations in 3 different areas. 1 is malnutrition, frailty, or weight loss. 2, hyperglycemia, DM or NODAT. And 3, weight management. In addition to findings from the literature review, I also spent time observing the post-lung transplant clinic. During this time, I evaluated current practice guidelines and completed a series of key informant interviews of members of the interdisciplinary team to get a better understanding of the clinic flow and areas for improvement. For time purposes, additional methods beyond the literature review are not described in this presentation. If you are interested in reading more about how these recommendations were made, please request a copy of the final report. Each recommendation is discussed further in the following slides. This slide presents the proposed recommendations for patients who are experiencing malnutrition, frailty, or weight loss. The first recommendation is that weight at time of transplant be a required part of coordinator clinic notes. The reason for this is that currently, weights from the last 3 clinic visits are typically the only weights measurements recorded in the clinic notes. Having a baseline from the time of transplant recorded in all notes will allow all members of the interdisciplinary team to see the weight trend, even if the change is gradual from one appointment to the next. This will also improve interdisciplinary clinician communication in the event of clinician vacations or leaves of absence. The second recommendation is that all individuals diagnosed with malnutrition at time of transplant evaluation or during the perioperative stage are to have a mandatory outpatient follow-up with the transplant dietitian at 2 and 4 weeks post-discharge. Further follow-up to be determined by the RDN. The reason for this recommendation is that malnutrition is associated with higher mortality rate than an adequately nourished status. Those who are malnourished are more likely to succumb to infection, death from graft failure, and pulmonary complications. The transplant RDN is uniquely positioned to recognize the transplant patients at nutrition risk and optimize their nutrition status. The final recommendation is that patients reporting lack of appetite, taste changes, or that eating patterns are affecting their quality of life, or vice versa, are to be given a referral to outpatient transplant RDN. The reason for this is that malnutrition is associated with a longer length of hospital stay, increased mortality, decreased quality of life, and decreased functional status. Research has shown that a multimodal nutrition intervention, including nutrition counseling from a dietitian at 4 days, 30 days, and 16 weeks post-discharge, improved older malnourished patients' quality of life, nutrient intake, and physical function. This slide presents the proposed recommendations for patients who are experiencing hyperglycemia, DM, or NODAT. The first recommendation is that all individuals with a diagnosis of diabetes prior to transplant should see the outpatient transplant RDN at 2 weeks post-discharge. The reason for this recommendation is that pre-transplant diabetes increased the mortality risk post-lung transplant by 1.82-fold. Transplant recipients with DM have an increased risk for mortality, infection, and graft dysfunction. The second recommendation is that patients diagnosed with NODAT within the first year of transplant should be given a referral to see the RDN. The reason for this recommendation is that despite the finding that NODAT did not impact mortality risk, all efforts should be made to tightly manage blood sugar levels, as hyperglycemia has been associated with infection and graft dysfunction. The third recommendation is that patients requiring regular adjustments or increases in insulin doses should be given a referral to see the RDN. The reason for this recommendation is that RDNs play a pivotal role on the multidisciplinary team, and other approaches such as diabetes self-management, education, and support programs have demonstrated the effectiveness of a collaborative approach. Lastly, this slide presents the proposed recommendations for patients who are experiencing issues with weight management. The first recommendation is that no referrals should be made to the dietitian for weight gain within the first 6 months following transplant, unless the patient's BMI was overweight or obese at the time of transplant. The reason for this recommendation is that patients with a low or healthy BMI at transplant with a weight gain of greater than 10% at 5 years actually had a 64% decrease in mortality risk compared to those who maintained a stable weight. The second recommendation is that the weight at time of transplant should become a required part of coordinator clinic notes. This is similar to one of the proposed recommendations for malnutrition. The reason for this recommendation is that as weight gain tends to become a larger issue in the late stage of the postoperative recovery, having a baseline weight provided will allow all members of the interdisciplinary team to notice when weight gain starts to become significant. The final recommendation is that a referral to the transplant dietitian should be offered if patient's BMI passes 30 or jumps from class 1 to class 2 or class 2 to class 3 obesity. The reason for this referral is that results revealed that the intervention group experienced comparatively lesser weight gain than the control group in the Emsley study. There's a considerable amount of evidence to consider before making those proposed changes, so now let's discuss future directions. While TGH has an established framework for post-transplant patient care, there is discernible need for more structured and comprehensive approach to nutrition intervention. This is not just a matter of policy, but requires changes in practice, bolstered by efficient communication among the interdisciplinary team and active patient engagement. Ensuring that nutrition gets its due attention can play a transformative role in enhancing the quality of life and long-term health outcomes for these transplant patients. This is a list of all the references that were cited throughout this project. I appreciate your time. If you have any questions, they can be directed to me, my email's on the slide, or to the lung transplant dietitian, Stephanie. Thank you so much for your time.